Hey! Hello. Thanks for having me, and genuinely, thanks for being here. This is an extraordinary and truly magical thing. The NHS analyst community, I think, is the hidden gem of the NHS. It's a tragedy, the extent to which, over the course of the last few decades, it has somewhat disappeared from view. I think it's a natural consequence of the way that the NHS is organised. The NHS is not a mammoth, it's a shoal. And the trouble with that is, the more dispersed people are, if you don't have a structure around a particular community or a particular way of working, then it can get lost and you don't get the efficiency benefits of people sharing tools and knowledge and ways of working and training and everything else. So I think it is a magnificent thing that we're now starting to see that structure re-emerge over the course of the last few months. And I'm feeling very, very optimistic, which is, my standard demeanour towards the world. So, I'm going to talk a bit about the review. I'm going to talk a bit, I suppose I should mention sort of briefly who I am and why I'm here, I suppose. So, first of all, every now and then people say, why is this bloke who writes a column in The Guardian? I am a doctor, but that's not a good thing. And I'm an academic. I run the Bennett Institute at Oxford, and we're a bit unusual amongst academic groups in three ways, I suppose. The first is, we don't really prize academic research paper outputs above all else. We're really interested in, wait, have I sent the wrong? No. We're really interested in how you use data for practical service monitoring and improvement. So we build tools like Open Prescribing, which is a tool that anybody can use to look at variation in care in prescribing across the country. It gets about 28,000 unique visitors per month, and any interested party can generate graphs like these, looking at practice-level data, ICB-level data, and so on, to see which treatments are being used by individual GP practices down to the level of brands, chemicals, products, prescription duration even, and things like that. The second thing that we are interested in doing is building platforms that help other people work on data. So Open Safely is a platform that we built during the pandemic, where we wanted to address the challenge that people couldn't access GP data in a timely way, in a secure way, without making privacy campaigners and professional bodies anxious. And then lastly, allowing them to use it quickly and efficiently once they've got access to this data, because as many of the people in this room know, routinely collected electronic health record data is not for us. People say it's dirty. I don't really like that. We have to do the work to make it fit for analysis. So we built a set of standard tools to make it quick and easy to access. If you're interested in working on Open Safely, send us an email, go to the website, you'll find a contact. And I'm delighted to say that Ming Tang, in her infinite wisdom, is now supporting Open Safely. And we've got a permanent legal basis for COVID uses. And we hope in the future to be able to use it for non-COVID uses as well. So an opportunity there to look at variation in clinical activity and outcomes and all of the analytic approaches that you could possibly dream of on 58 million patients' entire GP records linked onto SUS, ONS death, vaccination, COVID testing, and lots of other things. And then lastly, to be able to do things like this, I don't just employ academics. I don't mind academics, I am a prof, but we don't just employ academics, we also employ people who have historically worked in service analytics, and we employ software developers, because if you're going to write a line of code, if you're going to analyze data rather, you need to write a line of code, and if you're going to write a line of code, some but not all of the people in your team need to know and understand, perhaps even be professional software engineers. Not all of them, but some of them as part of the portfolio of skills that you have. And I think that portfolio of skills is really important, because no one person knows all of medicine. No one person can possibly know everything necessary to deliver analytics. You need to have teams that have got a mixture of skills, and all of those skills are important. So sometimes it's critical to be the person who knows what GitHub is and how to write unit tests for your beautiful R package that you're going to upload and share with beautiful documentation. Sometimes it is absolutely legitimate to have somebody who only knows how to do point-and-click analytics, but who's really, really good at communicating information to managers. Or, as Peter was rather gently alluding to, dealing with a manager who doesn't know how to ask good questions of the data that is around them, and coaching them and helping them and working with them on a one-to-one basis to get them to the point where they can understand what's fast and quick and matches their needs, and how they could rotate their analysis by 3 degrees to the left and get something that would get almost everything that they wanted and more, but be a tenth of the price. So, that's what we look like. Let me tell you about the review. Firstly, as people have alluded, it was rather long. In our defense, they said, can you get a move on and do it in about 4 months? And we did. We handed in 30 pages. And then they said, oh, this is great, but can you give us lots more detail on exactly how we do it? And we said, are you sure about that? Because civil servants historically just have quite bad antibodies to that. They just want to be told high-level things. But no, really. So we said, okay. And we handed in 80, 90 pages. And they said, oh, this is great. Can we have a lot more on exactly why you think we should do it like this? So then we said, fine. Went back about 3 months later with 220 pages, and everybody burst into tears. Anyway, it sits in a glorious and sort of crowded context. There are a lot of people talking all the time about how to do data analytics and how to make better use of data. We've read them all. Some of it was archaeological, some of it is stuff that's come out since. They've all got a lot of very recurring core themes. First of all, reduce the number of places that data is collected, stored, and disseminated, because that's better for privacy management, for efficiency, reduces duplication of work. Secondly, make data accessible through platforms rather than by emailing copies out, rather than housing it in multiple different locations where you can't be sure what's happening, but also where you can't constrain the explosion in duplicative work. Thirdly, upskill the workforce so that they can work not just better, because better is not very helpful, but to embrace modern, open, collaborative approaches to computational data science, which I'll talk about in a mo. Put in place legislation standards and cunning organizational design to help avoid the problem of data access being monopolized. Because I'm not directly employed, I suppose, by the NHS or by monopolies, people get a bit anxious when you talk about it. They are a terrible recurring problem around the NHS, around academia, around the whole landscape of data. When we were doing the review, we had people come to us saying, oh, there's this big thing in my local area that's supposed to be a data platform. I've seen their PowerPoint slide decks at numerous conferences, but I'm not allowed to use it, and that's obviously unhelpful. Penultimate, put in place legislation and standards to make sure that there's meaningful transparency and accountability around use of data. And then lastly, try and standardize the way that patients and the public are involved. I think PPIE, as it is called, is incredibly powerful and important. I'm worried, though, when I can see lots and lots and lots of different duplicative low-level PPIE projects and very few big single authoritative pieces of work like citizens' juries, for example, on the really big questions. I think it would be better to do the big recurring challenges around patient and public involvement and engagement for data once and well. So, the review had quite an extensive terms of reference, but broadly speaking, it was how do we get better, broader, and safer use of health data. Now, this was a tremendous palaver. We spoke to 200 people up close, and I must say, it is an extraordinary thing to feel. I don't think I know more than anybody else in general about how data is used in the NHS, but for that brief moment in time, the three of us who were working core on the review, me and Nicola from DH and Jess Morley from my team, we had spoken to people from every corner, and you have, for this brief moment in time, this kind of overview. We did 8 focus groups, 100 written submissions, made 185 recommendations, apologies, 30 summary recommendations, and 110,000 words. Let me talk about data. The NHS, as everyone knows, is a truly magical thing. We have data on almost every citizen, covering almost every major clinical event. We've got 75 years of data, and actually paper records get computerized, so we go back to birth for most of these citizens for the headlines in their medical history. We've got this data on tens of millions of lives, but we've also got it on a very ethnically diverse population, which means that analytic outputs from UK data have potential to have impact on better choices in healthcare around the world. And data is a truly magical and efficient thing. It's how we find out which drugs work. It's how we spot side effects. It's how we spot problems in hospitals and surgeons with room to improve. It's how we plan services, and it's how we optimize care. But data doesn't do this on its own. It needs to be data quality checked. It needs to be reshaped and curated from the raw form in which it's collected as an aid memoir for patient care, or as a billing record, or as a prescription artifact moving from a practice to a pharmacy. It needs to be housed and managed securely. It needs to be analysed by people who have skills and knowledge, and then it needs to be communicated and acted on. Now, all of that takes a lot of time and effort, a lot of coordinated work, which has historically been allowed to emerge in a rather potluck fashion. In the review, there were 5 themes. I'll talk about each of them very quickly and then talk about analysts in particular. So first of all, platforms. If you say, show me NHS data infrastructure, the picture would probably look a little bit like this. There's huge duplication of work on curation, on housing, on information governance for access. That, again, risks monopolies and poor privacy management. When the data moves around the tangle, the way that we try to manage privacy is through 2 techniques. Firstly, pseudonymization, take off direct identifiers like name and address. And secondly, through information governance, which is slow and cumbersome to make up for the shortcomings in pseudonymization. To be absolutely clear about whether pseudonymization works or doesn't, it basically doesn't. If you know a little bit about somebody, for example, schoolgate knowledge about when you had your children and where you were living at different times, I could find my wife in the GP electronic health records very straightforwardly. Baby in 2013, baby in 2015. The event codes moved from Bath to Oxford, Bath to London around 2010, and then London to Oxford around 2015. There's only one person like that. That's my wife. Do not go and look up my wife in the GP electronic health records data. But that is the problem with uniqueness. And you can see it very clearly. Also, this is an example used by security engineers a lot. If with Tony Blair, you know just from news stories that he had an abnormal heart rhythm reset in October 2003 and in September 2004. You know roughly where he was. You know roughly when he was born. Hands up, who can write a SQL query? Yeah, baby. Hands up, who's got a copy of Hez kicking around somewhere? Okay. And if you've got Hez on a machine where nobody knows what you're doing, I mean, I sat in an office not very long ago with Hez on DVD on a shelf, right? Nobody knows what I do with Hez on DVD. And if I type this SQL query on the right, when we did this first, people said, oh, don't do that. As if writing an adequate SQL query was the barrier to re-identifying Tony Blair in Hez, right? If you write this SQL query and plug it into a machine that's sat on top of a copy of Hez, you will get Tony Blair's entire medical records. So that's why pseudonymization, removing names and addresses, is not a sufficient privacy safeguard. And I think there was a lot of doublethink for a long time, and that was really unhelpful. And it cost a bit of pain and anxiety going around the system saying we've all got to be a little bit more realistic about the privacy benefits of pseudonymization. And people go, oh, but it's so helpful to say that it's good. But I'm really glad that we've moved on from that, and I think that's really important. Now, that's certainly not to say that there are a sequence of privacy catastrophes waiting to happen across the system. I think there are some corners which are really problematic, and I'm really glad that those are being scooped up and replaced with better ways of working with very detailed national level data in particular. But the main problem is not that it was total anarchy, but rather that the challenges of pseudonymization were then managed with information governance that was so slow, so painful, so dreadful, that people would take years trying to get access to data and sometimes never get it at all. And there was also arbitrariness. People with perfectly sensible projects and perfectly sensible ways of managing the risks around data would get blocked, and then you'd discover some strange corner of the NHS where vast amounts of data were being exported and sent out to all kinds of different locations. So information governance is not a good way to make up for the shortcomings around pseudonymization. So the big recommendations that we made that I am delighted have been taken forward are to make the norm to be one of accessing data in platforms, secure analytic environments, rather than disseminating data out to multiple different places, to be realistic about the shortcomings of pseudonymization, and then to use the enhanced benefits, and this is yet to come, but I'm feeling optimistic, to use the enhanced privacy benefits of TREs, or the NHS decided to call them SDEs. Reminded me a little bit of, do you remember when the NHS didn't want to use email? It invented its own email called NHS Mail. Anyway, so use the privacy benefits of TREs, or as the NHS wants to call them, SDEs, to make it quicker and easier for people to access data, because you have managed the information, the privacy risks around people working with the data. And then lastly, use the platforms as a way to try and get harmonization of the way that people are curating data and working with it. Next, modern open working methods. So there is a problem in the way that people work with data, and it's a problem across the whole of government, and it's a problem that other parts of government addressed with...
David Halper.
Oh, no. It's quite unfortunate the way it shouts the name of the person who's calling. Now you know. Anyway. So, modern open working methods for data. So, the traditional way of working with data across government, which was recognised by ONS and Government Digital Service a long time ago, is that basically you telephone Barbara, and Barbara will do something called a SQL query for you, and she'll put something that she calls a flat file in the shared drive, and then you'll do something in Stata to fix the dates, and then actually we prefer to use Power BI, not Tableau, but try and sit next to Sally, because she'll tell you how we normally make those dashboards, and then print them as a PDF, and then send them over, and he'll put it in the report in the Word document that's on SharePoint. We're very digital. And these manual ways of working with data, they're very inefficient. It's very hard to update your work. You don't get to press a button and the whole thing filters through. But they're also not very auditable. You can't see what happened. And when I talk about the benefits of open code, it's not particularly about transparency as a moral good. It's about the practical benefits that come from sharing your code, sharing your working, being systematic, and embracing modern open ways of working. So in ONS and Government Digital Service, they developed a brand called Reproducible Analytical Pipelines, which encodes best practice in this space. And I'm really pleased to say that this has been really picked up by the NHS. This is from well, that's from ONS, but there's a slide I've obviously forgotten to put in, where NHS Digital, the chap who did it, is here talking about where's the NHS Digital person doing the rap talk? Like, it's you, hello! So NHS Digital have now embraced, well, NHS Digital, successor organisation, the bit of D now in E, is embracing reproducible analytical pipelines, modern open working methods, documentation, share and reuse, and better knowledge sharing. So next. Data curation. Peter, I think, very helpfully split out the tasks into curation, reporting, and then analysis. I think curation is actually the part of the process that's most at risk of being neglected. For example, with NHS GP data, you've got one row per event at the top, which is really rich and detailed, really privacy risky, but also really hard to work with. And what you want is something a bit more like what's here. Has this person got hypertension as an active problem in 2019? Yes or no? And you need to make that from the raw data, telling you about every diagnostic code, every systolic blood pressure reading, every treatment. Think about the number of people who've processed sus and hes into simpler variables for a particular report. Think about how many times different people have done basically the same job in hundreds of different places around the NHS. So we made a lot of recommendations about taking a more systematic and structured approach to data curation, knowledge management about data curation, and then most importantly, NHS data analysts. So in about 2018, I did a paper, it was published in Journal of the Royal Society of Medicine in the end, that was with some people who are here today, including Andy Orlovsky and others, looking at challenges in the analytic workforce and the structures around the analytic workforce. And it's really exciting to see how much has changed over the course of the last 5 years, thanks to folks like Peter and Ming and others. The NHS analyst workforce has got enormous diversity. It's got areas of best practice, which will, of course, be well represented here today. But the problem is, because there's a culture and a history of people working in a very isolated way with their own data analysis environments, with their own small communities. It's very hard for best practice to spread. There's been historically very little culture of people sharing methods or codes between teams, except in an informal way, like a kind of oral tradition, like the sort of thing that Cecil Sharp might, when he went out recording folk songs in Somerset, right? That's not the same as having a coherent set of structures around the way that people work with data. So the recommendations that we made were, first of all, create an NHS analyst service modelled on the Government Economic Service and Government Statistical Service, with a head of profession, clear job descriptions that are tied to technical skills. Also really crucial, I think, just for the spirit of it, at the moment, NHS analysts, for the most part, oh my God, my mind's gone blank. What's the name of the ridiculous ontology of jobs in the NHS? Agenda for Change, yeah. In Agenda for Change, but it's such a bad name, isn't it? Anyway, in Agenda for Change, NHS analyst jobs are classified under administrative/clerical rather than laboratory/scientific. I mean, there's nothing wrong with admin stuff, but I don't think that's appropriate. Anyway, clear job descriptions tied to technical skills. Progression opportunities that allow you to become a senior analyst on a higher salary with recognizing your better skills, but without that being tied to how many people you manage, because that shouldn't be the only way of progressing in a technical field. And realistic salaries where expensive specific skills are needed. Next up, embrace, of course, modern open working methods with reproducible analytical pipelines and make that a core focus of training. Next, really critical that if you're going to start from scratch today in the era of things like the internet, which you might have heard of, you want to make sure that all of your training opportunities are openly shared to everyone. None of this stuff should be a secret, but you also want it to be structured, tied to initial training and then continuing professional development that is mapped onto job descriptions, and you need all of that training content to be open to all. And you also need to represent the diversity of skills that people need, so not just being a heads-down geek using Python and R, but also data communication. Next, recognize the value of knowledge management. So there is a challenge when you've got so much great stuff happening across the system. How do you spread it around? Good knowledge management, good data curation, good librarian skills to share best practice, to index things, to help individuals who want to find out about what other people are doing on another part of the country in a related field, find out what they've done and how you can reuse it. And this kind of skill set is, I think, almost unnamed in all of the parts of the community that need it, including, by the way, research. Then lastly, seek expert help from academia and industry, but you've got to make sure when you do that you don't have a one-to-one relationship, a secret relationship where nobody gets to see what they gave to you, what they made for you. It always has to be open code, open methods shared to everyone in the community. And where you're getting people's help, you've got to buy out the intellectual property, not just get it in a secret one-to-one relationship. And then lastly, you've got to train senior leaders in how to be good customers of the data. So, it is magnificent. 5 minutes, all right. It is magnificent to see you here today. It is magnificent to see so much great progress, and there is great progress across the piece. There are people talking today from NHS England about some of the platforms that they're building, about how they're embracing RAP, around how they're building new workforce plans and capability and new training. And none of it will be perfect, and none of it will ever be perfect. And you need to be the people who lead this. And I think it's really important to be clear as well that that will be hard work, and it will often be unrecognised and under-resourced when you start out. My recommendation to you would be, first of all, to be propositional. You're the people who know the kinds of help that people in your community need. You're the people who know the kinds of help that could be stood up very quickly. So if you've got an idea for a training program that you think would meet the needs of a sort of reasonable constituency of analysts around the country, then write it down and propose it. Now, the second challenge is, where do you go with that? Well, of course, you can hurl it at NHS England and the national analytics teams, but the reality is you might also need to be entrepreneurial, because you're trying to build a railway, not use it. You've got to lay down the templates and the pathways for future people to take for granted. So you might need to work outside your job description to push forward on this, in the way that Peter and others here have today. You might need to work out how you can extract cash, because there are large volumes of cash flowing around the system that get spent under badges of training and capacity building. And you might need to have deploy some cunning to work out how you can divert that to projects that you think would be beneficial to the system. And I suppose the last thing in this demotivational segment is, when you've done it, it will feel so obvious that nobody will really recognize that it ever needs doing. Does anybody know about Virchow's triads and Virchow's nodes and all that stuff? There's this bloke called Virchow. All he did was get born at the right time in about 1780, and there's about 100 things in medical textbooks named after Virchow, because nothing had a name. They hadn't done anatomy at that stage. They hadn't done basic physiology at that stage. So Virchow, to my mind, sort of walked around just going, well, that'll be my triad, those will be my nodes, right? However, actually in reality, I've got no doubt whatsoever that that was a massive uphill struggle. I'm sure everybody who did everything that we now take for granted as obvious, in medicine, in analytics, in almost everything in society, when they were doing it at the time, they felt like it was pushing water uphill. It felt like an uphill battle until it became normal and boring. You are the scions of normal and boring. You're making tomorrow's normal and boring. And I'll leave it there. Thanks.